Hi, thank you for joining me today. I wanted to review a podcast that I have found, and this is a bariatric surgeon from 2016. He gives a nice overview of his interpretation of revision surgeries. He compares and contrasts the different types of weight loss surgery we've had. Um, and he goes over all of them. He goes over the Lapband, he goes over the RNY gastric bypass, and he goes over the duodenal switch, and he actually goes over the VSG, the duodenal switch, and then he also goes over the SADI SIPs. So he goes all of the weight loss surgery, and I found that he reviews these procedure in a very easy way for us to understand in the weight loss community. And I think he explains everything in wonderful detail. Some of this information is so valuable, not only for pre-op people who are looking to decide exactly what type of weight loss surgery they're going to have, but also down the line when some of us have some complication for whatever reason, and he'll list it on the video. I think this is a valuable resource for us to have as a tool so we can review, and I want to present this to you because I found it, and I haven't found anything that is very simplified and easy to understand. So I'm going to review it right now, and I'd like to share it with you. So basically, this is an introduction. He's going over the procedures of why again are we going to have a revision for a weight surgery procedure, whether or not, as it turned out, we didn't lose all our weight, or maybe we had a complication with the surgery itself. Maybe we had chronic reflux disease. Like me, I've had issues with my Lapband since 6 months out, and I've been suffering. Unfortunately, I have no recourse at the moment. But he's talking about why again someone or something failed. Did we fail or did the procedure fail? He's going to explain it. Did someone or something fail? Did the surgeon did it? Did the procedure do it, or did the patient did it? Now, I was told by my bariatric surgeon that I wasn't just doing it right, you know. I wasn't. I wasn't. I was secretly eating, or I was not eating the proper things, or I was causing my vomiting, or I was causing my reflux, or I caused my hiatal hernia to come back, or my dilated esophagus, I caused that, right? So here we go. Let's review it together.
In the office, because of the nature of our practice, of fair amount of divisions coming to us, the most common questions end up being that, what failed? Why am I having to have weight loss surgery again, or having the revision done? Did my surgery go anything wrong? Did the procedure didn't work for me, or did I do something else? Interesting enough, from my perspective, the answer is probably all of the above or none of the above, and most importantly is the expectation. I will, when I see patients in the office for revisions and all.
The expectations. I paid $7,000 out of my own pocket for an inadequate weight loss that I would like to maintain throughout my life by putting in it. What it cost me, the weight loss surgery was $15,000, but I paid $7,000 out of my pocket. I don't know. It saved my life, but long term, I don't think it's really that beneficial long term.
I go to the numbers. I will say this is what my weight at surgery was 20 years ago. This was my height. And also do the quick and dirty math on the paper. And I'll say, well, I'll venture to guess that this is your weight is, and honestly not really knowing what their weight is, I'm not guessing the numbers magically or being psychic to figure out a number. All I'm doing is applying the math and the statistics that's out there. So it appears that most of the time patients were led to believe, misled, misinformed that the weight loss surgery was going to do better than they thought it was going to do better. And then when the weight loss...
So he said the weight loss surgery was going to do better than we really thought it was going to do, right? That that we had this magic these magic ideas in our head. Some
surgery performed as well as it's supposed to, and that's far below what the patient expected. The assumption is that the weight loss surgery failed, which is not the case. A great example of this.
So he's saying that when we don't get to our goal, which is our 100% maximum weight loss, if we don't get to a normal BMI, he's saying that the surgical procedure didn't fail.
Is Lapband, which was promoted to be the similar and equal weight loss procedure. And when the patients fail, there's always a sort of comment, well, I did well, so I was turning up every day, and my weight was coming down, and I got pregnant, and I gained the weight back. And no one is going to be able to what has nothing to do with it.
So he's saying that a lot of people complain with the Lapband because a lot of us get pregnant, we gain all our weight back.
So it's more of an expectation. And the last scrutiny the consent is what I'm talking about a little later on. I find myself repeating myself like a broken record as to how procedures such as system SADI are not the same as the organ storage. They're different procedures.
So he's saying he's going into the SADIs and the duodenal switch, how they are really different. So we better not get them mixed up.
Important to appreciate that the procedures are different. Just briefly, let's talk about that. On the screen right is normal enough.
So he does deliver a nice, really comparison and contrast with the two procedures. He's doing the normal anatomy on the right side, the sleeve gastrectomy on the left side, and he's comparing the normal anatomy of the stomach to the gastric sleeve, which I think is fantastic. I'm going to link a card so you can go back and review this. He gives a wonderful explanation of the surgical procedures and how they are different and how they help metabolically and how they can reverse some metabolic issues that we have as far as comorbidity issues.
On the left, on the screen left is the gastrectomy. No differences are the stomach, the small bowel is unchanged and unaltered. And talking about the sleeve and the first slide coming up, and also talk about it in a little more detail, is the sleeve primarily works by two mechanisms.
So then he goes into the next discussion. He's going to talk about bougies, right? And that's a big discussion within the sleevers because it was thought eventually, or in the beginning, that the size of the bougie depended upon the size of the stomach to depend on how much weight loss you lost, right? But clearly, Dr. Keshishian explains that that's not necessarily true.
The volume restriction, which is the obvious one, and maybe there's delayed effect, delayed function of this may be the underlying hormonal changes of the ghrelin, for example, and the acid that's removed and may reduce the protein breakdown and protein glucose.
So what he's talking about is our metabolic issues as unique as a human being, because we're all not the same in how we digest our food and our metabolism and our ghrelin, how much is in our stomach. So he's basically saying that we're all different, and they don't have like a crystal ball.
Fortune. It's been studied over and over again that the size of the bougie within a certain limit really doesn't matter. So this notion that patients will ask each other, well, my bougie is just like what's yours, and things like that, it really becomes irrelevant. On a personal experience level, the way I practice it is better fun to have when a patient comes back and says, I have not lost that last 20 pounds or so, versus the patient that comes back after the blood and food or the sleep, and they have they're debilitating weight loss, or they have significant solid intolerance. Both of which mean that the feeling.
So what he's talking about when we go back for a revision, we really have to have a heart-to-heart talk with our surgeon as far as our expectations are concerned about our revision and what we expect in our weight loss and how we expect our health to improve with this revisional surgery. I think there's two issues to look at. We look at aesthetic reasons and the reason why we want to lose our weight, the reason why we want to get at our normal weight, because we want to feel good about ourselves, because for so long we've been overweight and obese that we want to be attractive, we want to have a good time, we want to enjoy our life, we want to eliminate possible medical diseases, we want to eliminate our possibly our diabetes and get off medications. Some of us want to conceive, some of us can't conceive because we have obesity in the way. So yeah, of course we want to get back down to our natural weight, the weight that we're really supposed to be at.
And as I said, within a scope of broad range, when you look at the outcomes of weight loss surgical procedures, specifically the one to and the sleeve, there's very little variation between the stomach, the tight versus very tight versus medium or large. And we're talking about the bougie size of 30.
So he's talking about the outcomes of the bougie and how much weight is lost. And he's talking about the surgical, as far as the surgical anatomy of the stomach, and how they evaluate the anatomy and how it compares to the weight loss in numbers.
So also switch operation by definition, the image on your left side of the screen has two anatomies. One is out of water and
So he's going through the anatomy of the difference between the duodenal switch and the SADIs and the SIPs. And he's saying that the SADIs and the SIPs only have one anastomosis, and the duodenal switch has two anastomosis in the duodenum and at the distal small bowel. So he gives a nice presentation of understanding all the anatomy and where it's actually hooked up. And it's important for us to understand this if we're going to have this weight loss procedure and we're going to have a revision, or even if this is the first procedure you're going to have. It's really important to understand these procedures and how it affects your body so you're more comfortable and you know exactly what they're doing to your body.
with a forward motility movement of such is and because of the fact that as the food travels down the stomach, as issues, solve diabetes.
Sorry, I lost my place.
Or they have significant solid intolerance. Both of which we're going to have physiologic problems. I'll talk about it in slide later, what it has to do with the pressure and the volume. So on the left-hand side, now we have the dual switch, and on the right-hand side, we have the sleeve. The sleeve we talked about previously, and if you compare these two procedures, the stomach size is the same, and the dual switch is where the reduced absorption takes place.
So he's talking about the absorption in the duodenal switch.
I strongly believe in the dual switch procedure. And one of the things that I really need to bring to our attention is that the patient that's having the dual switch is able to get a custom tailor-made procedure that meets all of their metabolic requirements. So a patient that makes.
So he's saying with the duodenal switch, he does a custom procedure on the switch where he wants to look at all your issues. Say, for instance, if you have metabolic issues, if you haven't lost all your weight issues, these kind of things. He say, for instance, if a person comes to him in for a revision, and she only has 50 or 25 pounds to lose, he won't make the stomach as small as somebody has to lose 200 pounds.
So high cholesterol and high triglycerides, we'll be able to have the dual switch operation done by relatively larger stomachs that have short common insulin to be able to minimize their metabolic issues, solve diabetes and so forth, without really causing a lot of weight loss. That's an example of how when I use the dual switch, I'll tailor the procedure to be able to address individual patients' requirement that I don't sort of, we don't quick set a procedure where every patient needs to get the same food. And again, I'm sort of setting the foundation, talking about what some complications are, why a patient needs to use revision. When you talk about the length of the small bowel, dual switch is available to prescribe procedure. Your common channel should be between 50 to 100. I'll mention a certain percentage. And so we already.
So I really think this podcast is really, really interesting. I'm a science geek, and actually he goes into an actual Lapband procedure, a procedure where he revises to a Lapband to a, I think it's a sleeve, RNY, because he doesn't advise Lapbanders, especially if you've had a problem with reflux. He definitely says that you don't want the sleeve. You don't want the sleeve. He says it. He says you need to do RNY. Well, actually, he suggests to do the duodenal switch and get a smaller stomach if you only have 20 more pounds to go to lose all your weight. Or if he'll customize the switch, the duodenal switch, to your needs. But I think it's a very, very interesting podcast. And for anyone who is researching a revision, for anybody that's starting out and researching what type of procedure that would be good for you, I think you really want to look at this video, because I haven't found anything on YouTube yet that goes over the highlights and some of the questions or some of the things that you might bring to your surgeon's attention. And also it gives you a roundabout way of how the procedure is going to work, how your new anatomy will be, and some of the complications that could go down the line. There's on his channel, there's a lot of other videos, and he talks about other things concerning weight loss surgery, so you might want to check it out. So anyway, I thank you for tuning in. If you give me a thumbs up, if you'd like to make a comment, I'm going to be making more informational videos, educational videos surrounding weight loss surgery. So you might want to tune in to the next video. Thank you and have a great day.